Thank you, Dr. Amal, for the kind introduction, and I'd like to thank the SSBMT SSH for the invitation. So the task I was given today is to talk to you about CML 2026, Achieving Treatment-Free Remissions, Patient Selection Algorithm. So what we will discuss today is the history of TFR, trial data supporting safety of initiating TFR, and TFR in patients with high risk of failure and adverse events from TFR. So the history starts back in the early 2000s. And this review was written by the late John Goldman in 2006, which is 20 years ago, about his vision of what might happen in the future and whether TFR is a possibility or not. And one of the quotes in his review is whether the continued use, at that time, people didn't know whether TFR is a realistic possibility or not. And what he said is whether the continued use of imatinib in a patient who has not yet acquired population of mutant stem cells, so only cells that have got the BCR-ABL, will prevent disease progression in the long term, in which case such patients may prove to have been operationally cured, thus foreshadowing the development of TFR in the future. In the review article, there was this scheme which shows the stem cells, and here is the quiescent stem cells. And when we do allogeneic bone marrow transplant, we replace these stem cells with donor stem cells, and that's how we achieve cure in CML by allogeneic bone marrow transplant, which was the way in late 90s and 2000s. Imatinib and TKIs in general will affect these cells, the cycling stem cells, and they might lead to the abolishment of these cycling stem cells. And whether this abolishment will lead to long-term remissions and maybe curing patients, some patients, is what was thought about in that time. So in 2002, there was this paper, a follow-up of cytogenetic remission in chronic myeloid leukemia after cessation of interferon alpha, which was the treatment of choice in the 90s. And this has shown that some patients who stopped interferon alpha and they were in complete cytogenetic remission, they had no relapse. 50% of these patients did not relapse for more than 2 years after stopping interferon alpha. And they were wondering whether these patients have been cured of their CML with interferon alpha. 2 cases in 2004 reported in the literature, and these 2 cases, one patient remained in a long-term remission after stopping imatinib, and the other patient relapsed. So people were thinking whether stopping imatinib after some time will lead to a long-term remission. So in 2007, this was the first trial of TFR. 12 patients were enrolled in this trial. And the first patient enrolled remains in molecular remission 20 years after starting TFR until today. And this is one of the longest reported cases of TFR was from this trial in 2007. And then after that, after 2007, several trials became using TFR with different indications, with different rules. And these are some of the trials that have been reported to date. And EuroSki is the largest trial to be reported, more than 750 patients in this trial. And the majority of the trials actually report a success rate of about 40 to 60%. So we'll discuss the largest trial that was reported. The rules for this trial was that the patient should be on TKI for 3 years or more and should achieve a deep molecular response defined in this trial as an MMR of 4 for a year or more, and no history of TKI failure. The follow-up was doing PCR every 4 weeks for the first year, and then follow-up with 3 monthly PCR. So this reported the primary endpoint was molecular relapse-free survival. Molecular relapse was defined as the PCR level goes above 0.1, which is MMR3. And what has been achieved is that after 6 months, 61% of the patients were free of relapse. The secondary endpoint was to look at those who relapse in the first 3 years, and those who are free from relapse were 46% of the patients. And this is the curve reported in the article. And the second thing that is important in any TFR trial is to see if there are any patients who actually progress or die of reinitiation of TKI, that's saying they develop blast crisis. And you can see here the red line is patient discontinuing TKI. This is the mortality of these patients, and that's not been increased compared to the general population, telling us that it is safe to stop and do a TFR on some patients. This is the patient's overall survival, and also how quickly the patients went back into remission if they lost their MMR. And you can see that there is a separation between patients who relapse within 6 months of stopping versus patients who relapse after 6 months. And this table will show you how quickly patients go into molecular remission after their relapse. And 28%, those who relapse within 6 months, will go into remission in 3 months. And after 6 months is 52%. So telling us those who relapse after 6 months will go quicker into remission when you restart the treatment. And again, there is a difference between 6 months and less than 6 months and more than 6 months, 71 and 92, but at 1 year, 85% versus 96% getting into remission. So who lost MMR after 3 years of follow-up? So there are patients who lose their MMR even after 3 years of follow-up. And in this EuroSki, 111 patients lost TFR after 3 years. 11% of these patients lost it in 3 years after the first 3 years of follow-up. And the reason for loss of MMR is if their MR4 is lost. So patients whose molecular level is 0.1 to 0.01 during these 3 years tend to lose more their remission. And patients who maintain their MMR4, only one patient lost their PCR after 3 years. So maintaining an MMR4 is a very good prognostic value at 3 years. So conclusion, the study defined the stopping criteria for CML who achieved durable remission. Preferred cutoff at 6 months is TKI duration of 5.8 years. So if you have TKI for 5 years or more, then you are good prognosis. And MR4 at 3 years is a good prognosis. So if you maintain MR4 at 3 years, is a good prognosis. So this is another trial of ASTIM trial. And in this, they've also shown again that those who maintain MR4, 18%, will only see loss of their PCR if they don't maintain their MR4. If they lose MR4.5 on 2 consecutive readings, also is a bad prognostic indicator. So conclusion of this study, the vast majority of patients who maintain TFR for 2 to 3 years have not lost MR4 over the period of time. The risk of relapse is very small if you maintain MR4 at 3 years. And nevertheless, ongoing patients, even after 3 years, can still lose their PCR-able level. Who's good risk from these studies? Analyzing MMR maintenance on the entire 36 months, duration of TKI. So patients who maintain TKI for longer have a better outcome. Duration of deep molecular response is a good prognostic factor, and peripheral blood blasts at diagnosis is a good prognostic factor. And finally, patients who have the E14A tend to do much better than those who have the breakpoint at E13A. This is a study from the MD Anderson showing patients who have a MR4 for 5 years or more versus patients who have MR4 for 2 to 5 years. And you can see clearly that the TFR success is better for patients who have a longer duration of MR4 of 5 years. This is MR 4.5, and again, there is separation between patients who have the MR 4.5 for 6 years versus 5 to 6 years and less than 5 years. So the longer the MR is, the better the outcomes of TFR. This is a patient of 4.5 with 4.5 years versus less than 5 years. And this is MR4 5 years versus less than 5 years. And you can see here clearly that patients who have MR 4.5 for 5 years or less than 5 years actually do the same as those who have 4 for less than 5 years. So conclusion of this study is that MR4 to 4.5 was the strongest predictor of outcome rather than TKI duration in this MD Anderson study. Another predictor is how quickly you halve the BCR-ABL. And the quicker you halve the BCR-ABL at the outset, the better the prognosis of these patients. And you can see here in this study that patients who halve their BCR-ABL in less than 9 days is the yellow line, and the top yellow line here is less than 9.3 days halving their BCR-ABL, and here the ones who halve their BCR-ABL in more than 21 days. So the quicker you halve your BCR-ABL, the better your outcome with TFR. This is, again, a statistically significant difference between those who have their BCR-ABL in less than 12 days versus more than 12 days. This is a meta-analysis showing that adding interferon for more than 12 months increases the benefit of having a TFR. So adding interferon to a TKI tends to improve the TFR rate later on. Another predictor in this meta-analysis is those who achieve MR5 tend to have a better TFR outcome. Another factor that was found in this observation study is that patients who have a second-generation TKI treatment rather than imatinib tend to have a better TFR rate, and this is a good predictor having a second-generation TFR. So what are the poor risk factors for achieving a TFR? Is high LTS risk at diagnosis, history of accelerated phase blast crisis, warning signs of not following the ELN guidelines, and having a failure at 3, 6, or 12 months is a bad risk. Switch to second-generation TKI for resistance, a total duration of treatment of less than 5 years, and a non-optimal duration of molecular response, less than 2 years and less than 3 years, and a use of 3 lines of TKI, and a history of BCR-ABL mutation. So all these are risk factors, but they shouldn't stop us from doing TFR. According to this study, Italian study, even those with 0 risk is the black line, and you can see their TFR is better, while those who have 3 of these high risk factors still achieve a good TFR, but they are lower than those who actually have 0 risk factors. So patients who failed to achieve a deep molecular response, this study was looking at this type of patient, can we still do TFR for them? And if they didn't achieve a deep molecular response, they changed them to second generation TKI like nilotinib. And they've shown that if they achieved a deep molecular response, they still can achieve a successful TFR. What about the second TFR? Those who fail to their first TFR, can we do a TFR a second time round? And this study shows that yes, we can do a second TFR, but the success rate is lower in the second TFR of 35%. This is a study, again, looking at those who failed their first TFR and getting dasatinib. And again, the probability of TFR is 61% at 6 months and 46% at 24 months in second TFR. Those who lose their TFR after 6 months tend to do much better than those who lose their TFR at less than 6 months. So patients who failed more than 6 months in first attempt tend to have, after 6 months, tend to have a success rate of 72% versus only 36% if they lose TFR less than 6 months, 66% versus 30%. So these patients who lose their TFR after 6 months tend to have a good prognosis. Patients with kinase domain mutations, people then not to include these patients, but there is some success in those who have tyrosine kinase mutation in this trial. What about prolonged treatment-free remissions in myeloid leukemia domain mutations? And this study is short in about 10 patients only. Patients still achieved a good TFR in these patients despite their tyrosine kinase mutation. What about cases with unusual BCR-ABL breakpoints, unquantifiable with standard PCR? Can we do TFR for these patients? Obviously, these patients are very difficult, but there is one case report from the American group showing that this very unusual case of a breakpoint of E19 and BCR-ABL transcript of the worst mutation possible, the T315I mutation, and they've shown that they followed this patient with Sanger sequencing, and you can see here they started the patient in 2015 on asciminib and monitored the patient with Sanger sequencing, and in 2022 they started TFR in this case, and the patient maintained TFR for now 2 years when they reported this case. So difficult case, but they still maintain TFR in such a very difficult situation. What are the predictors of success in TFR? Duration of TKI therapy, the percentage of blasts at diagnosis, the transcript type E14 is better than E13, and the TKI duration and stronger independent predictor than deep molecular response. Risk factors of doing TFR, this is an unusual report of patients developing a blast crisis after TFR, after starting, some started treatment, some didn't start treatment, but this is very unusual. Only 6 cases reported in the literature of blast crisis after the TFR, and this is the patients, some of them developed ALL, most of them developed ALL, rarely one developed AML. So it is postulated that blast crisis in those who develop TFR is less than 1 in 1,000 case. This is similar to incidence of patients who remain on therapy and can develop blast crisis despite being on a TKI. So people started putting guidelines and summary from personal looking at the data. I wouldn't consider TFR in patient with history of blast crisis or accelerated phase. I wouldn't consider in unusual BCR-ABL breakpoint unless you have very special Sanger sequencing or digital PCR. I wouldn't consider TFR in patients with BCR-ABL domain mutations. They are difficult patients to do TFR in. And I would consider TFR with other high-risk features like TFR after failure of TFR, but preferably after second deep molecular response at least 3 years. I would wait longer to initiate TFR and require deep molecular response, and maybe 4.5 rather than 4, if the patient had an E13 breakpoint, if the patient had high SOCAL score at presentation, and if the patient failed 1 line, not due to toxicity, but due to failure. So how do we prepare our patients for TFR? Patients tend to look at result. They want to know about result of trials, general information about the steps of how to do TFR, expectation in terms of risks and opportunities, and they want to know about withdrawal symptoms after stopping TFR, side effects from restarting, therapy, information about PCR monitoring, and psychological effects. So what is withdrawal symptoms? It was first reported by Johann Richter, and withdrawal syndrome is when happens in about 20 to 40% of patients who stop TKI. The primary symptoms are mainly newly onset of worsening musculoskeletal pain, which may include joint pain, arthralgia, muscle pain, myalgia, pains in the shoulder, hips, extremities, feet, and sometimes resembling polymyalgia or including muscle tenderness, occasionally accompanied by pruritus or rash. And the onset and duration is about 1 to 6 weeks after stopping a TKI. They are usually mild to moderate grade 1 to 2 and severe grade 3. The pain is typically transient. The management is usually, it resolves spontaneously within few weeks to even a few months. Sometimes the patient needs analgesia like non-steroidal anti-inflammatory drugs, and sometimes they even need, if they're grade 3, they need steroids. Risks of failure, longer duration prior to TKI therapy, older age, history of musculoskeletal issues, female sex, and possibly
Dr.
lower
Ihab,
body.
you're almost done.
Okay, I'm concluding now. Possibly lower weight and BMI, and prior use of higher report with second generation dasatinib. PCR-able frequency is 3 monthly first year, and this is, we'll skip this. The escalation strategy. Some studies have shown that patients might benefit from halving the dose for 1 year and then stopping. Don't stop suddenly. This is the escalation trial, and they've shown it is successful. The Chinese did a study of the escalation versus discontinuation, and they've shown that the escalation actually benefits patient more than this sudden discontinuation of TKI. So future directions, TFR is beneficial not only because of deep molecular response and duration of response, but also the immunity of the patient. And this study have shown that patients whose NK cells are healthier and more tend to have a better TFR and longer TFR. So finally, TFR is based on duration of response and depth of response, but also our immune system is very important for success. So take-home messages, prevalence of CML is expected to continue increasing worldwide. Survival rates have increased with newer therapies, and we are beginning to establish clear criteria for using TFR as a treatment option, and we may be able to increase the number of patients achieving TFR with more potent agents such as asciminib, and the patient perspective must be weighed when considering undertaking TFR. And thank you very much.
Thank you, Dr. Ihab.